Welcome to Endocast, the podcast where endodontics becomes clear, practical, and we hope a little less stressful. As always, hosted by Ahmed Shauki. Hi Ahmed.
Hi Francesca, and of course by Francesca Cerruti. Today we are diving into a topic that looks simple on the surface, but it's actually really underestimated.
Exactly, because we can shape perfectly, but if we do not irrigate properly, we are only doing half of the job.
Let's start with a simple question. What is the real goal in endodontic treatments?
Well, the objective of root canal treatment is adequate control of the resident microbiota through proper shaping, disinfection, and obturation of the root canal system. And this article shows clearly that bacteria have to reach a quorum of cells sufficient to cause disease. We call it bacterial load. So, before a threshold is reached, no clinical signs and symptoms of the disease are evident. After bacteria levels reach that level and exceed it, the infectious disease, so apical periodontitis in endodontics, becomes evident, is established. And if treatment procedures do not succeed in reducing the bacterial levels below that threshold, the disease will persist. But a successful treatment doesn't necessarily sterilize the root canal. We know we cannot do that. But still, it reduces the bacterial population to subcritical levels that are compatible to healing. For example, I had to treat this case with a sinus tract, but also I have a problem I cannot isolate here. So I had to raise a flap, do the pre-endo build-up, and then I did the root canal treatment. And you see that after 2 years, we succeed because there is no more periapical lesion.
And here is a challenge. The root canal anatomy is so complex. Isthmuses, lateral canals, and so much irregularities inside the root canal. So those areas, our instrument cannot reach easily. Sometimes cannot reach at all. So in isthmuses, for example, the only way to clean those areas is to activate the irrigant. So if the instrument cannot reach everything, irrigation becomes critical. And because otherwise we leave huge areas in the root canal space not treated. This case is obviously not okay because there are some millimeters of the root canal that are untouched by our instruments, the files. And this is why we will retreat it. In the same way, in these cases, if we had not cleaned and filled all these lateral canals, we would have left millimeters of the root canals untouched. And imagine, millimeters, it's like miles in real life.
Exactly. And we have to remember that microorganisms and toxins enter into the dentinal tubules of the root canal wall with an invasion depth of 200 to 1000 microns. So these diversity in root canals infection raise difficulty in root canal debridement. And the consequence is that the residual microorganisms can sustain the infectious state in the root canal, inducing persistent periapical tissue inflammation and leading to the failure of the root canal therapy.
So now we are aware about the problem that we potentially have. In fact, even after instrumentation, about 35% of the root canal surface area becomes untouched with our instruments, the regular instrument that you use that files. Regardless of the file, the technique used, moreover, we are dealing with a biofilm, and this is an ultra organized microbial structure, an environment that is highly protected by an extracellular polymeric substance called the EPS, which makes it very resistant to our therapeutic interventions during our disinfection.
Exactly. And we often hear the combo shape to clean and clean to fill.
Yes.
But as you can see in this case, here I have an endoperio lesion, and you see a huge pulp stone. I remove it, then I irrigate to see at least where the root canal openings are, and you see that after leaving the sodium hypochlorite in the pulp chamber for a while and activating it, the situation becomes more clear for me. Then I shape, irrigate, of course, then I activate the irrigant, and I spend a lot of time during this step. And then I fill. And what I see when I do the post-op x-ray, if you look carefully, look here, you see one, two canals in the major root, but also an independent portal of exit, which of course I did not shape because I had no idea it was there. Luckily, I was able to clean and then to fill it, but it was completely not intentional, okay? And so we follow up the case, and you see that over time the lesion heals. And of course, to make the perfect therapy after the endodontic healing, even the periodontologist, Professor Magnamensi in this case, intervened with a bone regeneration. And so we have the conclusion of the case. But we also have to start thinking about the fact that we clean to shape, because we don't want debris to pack inside of the root canal system, and we don't want to introduce again bacteria into the root canal. So we always have to rinse between the instrument and also clean the spires of our files. So these two processes are not separable from my point of view.
I totally agree with that, and we have to conclude from that particular case that shaping improves irrigant penetration and irrigation improves the shaping efficiency. So even if you don't know the exact anatomical shape or the anatomical features of the root canal, but if you irrigate properly, as in this case, you can effectively seal everything. So we have also to take into account the smear layer, because one of the key obstacles is the layer of debris that is blocking the dentinal tubules and prevents our irrigants from going deep, because as we said before, it penetrates into 100 to 200 microns inside the body of the dentin. So here is a key point. No single irrigant can remove the smear layer blocking the dental tubules alone, not even sodium hypochlorite. So the question is, how can we irrigate effectively? It is absolutely relevant to our clinical practice.
Yeah, and the first question is there an ideal irrigant? Because
Yeah.
there is an ideal irrigant, I want to use it. And then at which concentration should we use it? And how to make it reach the apical portion of the root canal? And also, for how long should we do it? Literature tries to help us defining this. So there is also a consensus paper examining all the irrigants and all the activation methods on the market, and they give some very clinically relevant advice from my point of view.
Yes, and it goes in consensus also with the original Grossman's recommendations or the requirements for an ideal irrigant. So, in theory, the irrigant should flush debris, mechanically flush debris, be antimicrobial, of course, because we are fighting bacteria, dissolve organic tissues, and that's the main objective of our irrigation. Penetrate deeply, be safe and non-toxic, be affordable because we need to use it every day, but in reality it doesn't exist. But as clinician, every day we need to treat teeth, and we want to do our best in order to reach areas that impossible to shape with files.
Yeah, so we have to look to the irrigants that we have available and see how we can combine them in order to achieve an optimal result. So we have to mix a little bit. So of course our irrigant of choice is sodium hypochlorite because it's an excellent dissolvent of organic tissue, and also it's effective against bacteria. So these are very important properties for an endodontist. And it's available on the market in different concentrations. So we have to understand between 0.5 and 8.25%, which is the concentration we are going to use in our treatment. Well, if you use it in a concentration that is higher than 2.5%, is going to be an excellent dissolvent of the organic tissues. But how does it react? When in contact with water, it splits, okay, and it becomes sodium and hypochlorite. And the typical effect that you will see when it's active against some tissue are these champagne bubbles. So when you see bubbling, it means that it's being effective against something. But it also has some limitation. It's toxic. Its action does not last long in time, and it's corrosive also. It stains. If you drop it accidentally on the clothes of the patient, it's a problem for you. And the smell is not good. And also, it only removes the organic part of the smear layer. And this is a problem. And also, if you use it in certain concentration, it can affect the mechanical properties of the dentine, such as microhardness, roughness, flexural strength, etc.
That's very comprehensive on the sodium hypochlorite because you just mentioned the action and limitations. On the other hand, EDTA, ethylene diamine tetraacetic acid, is a chelating agent and it targets the inorganic content of the root canal or the smear layer. So it enhances the action of sodium hypochlorite by removing that inorganic part of the smear layer. But it doesn't act on the organic tissue, and this we need so much. That's why we combine sometimes with certain precautions that we will mention later. Plus, it demineralizes the dentin, so it cannot be used as the last irrigant. And remember that very important point.
Yeah, yeah. Some clinicians also say that they use alcohol. Alcohol is
Yeah.
good if you want to really dry the root canal system because it reduces the surface tension and the root canal wall, so it can improve the penetration of the sealer. If you want to increase the bone strength of your post-endo restoration, you can rinse with alcohol. But on the other hand, it's not indicated if you are using hydraulic sealers because it's going to over dry the root canal system. So you might have some setting problems of your hydraulic sealer.
That's a very important point that we have to keep in mind because nowadays we are using hydraulic calcium silicate based sealers. Another one is a chlorhexidine, and it is really interesting because it is a strong antimicrobial agent, and we used to call it the cationic detergent because it acts by the cationic part on the microbial cell wall, and it has a long lasting effect because it has a substantivity effect adhering to the dentin. Uh, but no tissue dissolution, this is the problem, and no real biofilm disruption. It has to be combined with other irrigant in order to perform its action, meaning that it needs some help from other irrigants. On the shelf, we could also find some hydrogen peroxide with nascent oxygen that disrupts the biological activities of some anaerobic bacteria, and it is no longer being recommended as an irrigant because we have those functions from other irrigation.
And now let's go to one of the most overlooked aspects. So, what happens if we mix this irrigant? What are their interaction? Because, of course, they are going to interact with the substrate, with the tooth, but also with one another. And so we have to understand what's really happening when we put them together inside of the root canal system. For example, the tissue capacity of sodium hypochlorite decreases when we combine it with the EDTA solution because there is no free chlorine detected. So if we want to alternate these two irrigants in order to boost their activity, well, we are doing it wrong. And also, if we combine chlorhexidine with sodium hypochlorite, we might have problems, even bigger problems, because they create a precipitate which is potentially toxic and clinically extremely problematic because it's very difficult to remove and it stains the tooth and can also have a very not nice post-operative sensibility for the patient. So there are some problems in combining these two.
It's not only that, but also chlorhexidine does not chemically react with EDTA when mixed, but it forms a salt that is insoluble in water and it appears as a white precipitate. So when you mix them during irrigation, you can find it, the irrigation becomes having white patches or debris inside. That's why intermediate rinsing is crucial. Distilled water is often recommended to avoid unwanted chemical reactions between irrigants. For example, when you use sodium hypochlorite and you use EDTA, after you have to rinse intermediately with distilled water or saline. Effectiveness of our irrigant does not only depend on what irrigant we use, but also on the concentration, volume, time, and delivery method. But we will discuss this in the next episode because we have to go deep into this as it is into depth of the irrigation protocol.
Yeah, and if there's one takeaway from today is that irrigation is not accessory. It's central to success. So to learn how to do it at its best, you don't have to miss the next episode.
So stay tuned. Ciao. Bye.
Bye.